PEM, protein energy malnutrition, the name has been changed to severe acute malnutrition. We all know what it is. We have all seen movies and everything. And you have studied ComMed also. আর প্রত্যেকটা গভর্নমেন্ট হসপিটালে পুষ্টি ঘর হয় জানো, পুষ্টি ঘর হয় যেখানে নিউট্রিশনাল ম্যালনিউট্রিশন বাচ্চাদেরকেই ট্রিটমেন্ট দেওয়া হয়, বিকজ দে সাফার ফ্রম অ্যাকিউট সেটস অফ প্রবলেমস অ্যান্ড ইভেন ইফ ইউ গিভ দেম এক্সেস ফুড they will not be able to absorb it. So that is why they need special help. Now malnutrition, what is it? It is a consequence of inadequate intake of proteins and calories or deficiencies in the digestion and absorption of proteins, resulting in the loss of fat and muscle mass, weight loss and generalized weakness. তাহলে কি হচ্ছে, either inadequate intake হচ্ছে of proteins and calories or inadequate absorption and digestion. So the one is primary malnutrition, the other is secondary malnutrition. In the low socioeconomic countries, developing countries, primary malnutrition is a major problem, especially among growing children, as a result of which death rates among children is higher in these countries, especially under 5 mortality rate, which overall reflects the development of a country. The more the under 5 mortality rate comes down, that country has an overall better life expectancy and better development. So that is the primary malnutrition. We will mainly be dealing with primary malnutrition, but there is also something called secondary malnutrition, which you will be studying in the next semester. Secondary malnutrition are examples, Jano? Inadequate absorption of proteins. And absorption e kothay problem hoy? Name the disease. And mainly in intestines. Absorption kothay hoy? Intestines e hoy. To intestine er kon problem? You have heard of sprue, celiac sprue, tropical sprue. এইগুলো now এটা তো you know, appropriate diet should include sufficient energy by carbohydrates, also proteins and fats, right? তার সঙ্গে কি লাগে? vitamins, minerals আর fatty acids, minerals এর মধ্যে ক্যালসিয়াম, ফসফরাস, এগুলো মেইনলি. That's all you know. So in primary malnutrition, one or all of the essential components are missing from the diet. Primary malnutrition দুটো disease হয়. দুটো diseaseর নাম কি? Marasmus and Kwashiorkor. And secondary malnutrition results from malabsorption. Malabsorption syndrome এর মধ্যে celiac sprue, tropical sprue, gluten sensitive enteropathy. আজকাল অনেকে gluten free diet খায়, দেখেছো তো? gluten free সব খাবারের লেবেলসে লেখা থাকে, and they don't even know why they are doing it, but there are specific sets of diseases where the body is unable to absorb gluten, and then the person suffers from diarrhea and protein energy malnutrition. That is called celiac sprue. Then there can be impaired utilization of storage, excess loss or increased need for nutrients. Inadequate utilization of storage will be in liver disease. Increased need for nutrients in pregnant women, adolescent children and growing children. So basically this is a disease of poverty. We all know that. Malnutrition is basically a disease of poverty. When in poverty, in firstly poor socioeconomic countries. Apart from that, countries which are hit by war, there is political upheaval, especially among refugees. If you did a survey, your book says that among the children who are refugees from Syria, there are 60% of the children are suffering from malnutrition, especially protein energy malnutrition. Especially now there are also refugees from Ukraine, right? After that the book wasn't updated, but now there are refugees from Ukraine. So basically poverty and all, you have to write an essay like in English. So that is there. Apart from that, মানে এটা আফ্রিকাকে দেখাচ্ছে, কিন্তু আমি যেটা বললাম এভরি গভর্নমেন্ট হসপিটাল হ্যাজ আ পুষ্টি ক্লিনিক। পুষ্টি ক্লিনিকে গেলে কিন্তু দেখবে বাচ্চারা ভর্তি আছে আমাদেরই দেশে, ইভেন ইন দ্য সিটিজ, তাই না? সো ইট ইজ আ প্রবলেম ইন আওয়ার কান্ট্রি, ইটস আ মেজর হেলথ প্রবলেম ইন আওয়ার কান্ট্রি। নাও apart from that, acute and chronic illnesses, right? Suppose chronic illnesses like say cancer এ cachexia হয়, that is also malnutrition. AIDS people are severely malnourished, they are very thin, they are severely malnourished. মানে when you become older and you will see that firstly we have to screen in একটা তো হচ্ছে যে blood transfusion, when you are taking blood from donors you have to screen, so you have to be aware. Apart from that, you are doing a procedure, you have a patient, you are doing a procedure, নিজের safety টা important. So whenever we see, মানে in general when you become interns, house staff, when you practice, you will see that a thin patient has come, very thin malnourished patient with wispy hair and everything, and has a history of travel to other places, or her husband has a history of travel to other places. We will screen these patients for what? Will we screen these patients for? Immunosuppression, especially HIV, right? So you have to remember that HIV patients are also severely malnourished. নিজের সেফটিটা এদের উপরে প্রসিডিওর করবে, দুটো গ্লাস করে করবে। ওকে, ক্রনিক অ্যালকোহলিজমে কি হয়? ডেফিসিয়েন্সি কি হয়? ইয়েস, হোয়াট ইজ ইট কল্ড? থায়ামিন বললো একজন কেউ, হোয়াট ইজ ইট কল্ড? না, সিন্ড্রোম বা ডিজিজটার নাম কি? Yes, Wernicke-Korsakoff encephalopathy. So that, then there's ignorance and failure of diet supplementation. This happens even in people who can afford food, but they don't recognize that this person requires more food or requires specific sets of food or more protein. Say growing children are not being given adequate protein, or even if children are fussy eaters, they are not exactly malnourished, but they will definitely be underweight, especially among higher socioeconomic people. Most children become fussy eaters, it's a specific term, fussy eaters. These fussy eater children also are usually underweight or may be suffering from some deficiencies, especially iron deficiency. Among growing children, iron deficiency anemia is very common. Self-imposed dietary restrictions. Now this was not a very important topic previously, but now it has become, especially in developed countries, it is a more of an important problem. Mostly, like in our country, especially in a government hospital, when you practice, you will see lots of children who are malnourished. When you go and practice in say UK or USA, you will see many children, especially adolescents, will come with eating disorders, because they have this body image issue and everything, and they are either anorexic or bulimia. What is anorexia? খায় না কেন? না আমাকে দেখতে ভালো হতে হবে, রোগা হতে হবে, to the point that that person may die of severe malnourishment. That person is anemic, bone marrow is excessively suppressed, absolutely very few cells, very low cells in the bone marrow. In spite of that, the person is not eating. This happens. We have heard news stories of models dying of anorexia. Apart from that, bulimia. What is bulimia? বমি করে, গলায় আঙ্গুল দিয়ে বমি করে দেয়, they come with teeth problem. So this is a very very common. ওই ওদের দেশে যদি গিয়ে প্র্যাকটিস করো দেখবে ওখানে বা পেডিয়াট্রিকে মেইন প্রবলেম হচ্ছে ইটিং ডিসঅর্ডার বাচ্চা চলে আসে, very common. So self-imposed dietary restrictions. Apart from that, I've already spoken about malabsorption syndromes like tropical sprue, celiac sprue. Inadequate TPN. What is TPN? Total parenteral nutrition. There are some people who are unable to eat, so they are given total parenteral nutrition. The nutrition is given through the IV, right? So if the TPN is inadequate, of course this person will be malnourished. And then there are some genetic diseases which also can cause severe acute malnutrition. The WHO defines severe acute malnutrition as a stage characterized by a weight for height ratio, that is 3 standard deviations below the normal range. You have understood? It is a common pora. Weight for, that is how we assess the nutrition, weight for height ratio, especially among children. So, eta ki? Have you seen this? It is given at birth to every child. What is this? Immunization card থাকে, তার আরেকটা পাতায় এইটা থাকে. This is a growth chart. এখানে weight for height ratio দেখা হয়, whether it's above normal or below normal. Dietary intake of proteins and calories is inadequate to meet the body's needs. And the examples are marasmus and kwashiorkor. তোমরা তো যাও না ওই যে কমিউনিটিতে যাও তো কমমেডের, তোমাদের এখনো স্টার্ট হয়নি কি? স্টার্ট হয়েছে কিন্তু যাওনি? আচ্ছা, যেই গ্রুপের স্টার্ট হয়েছে তারা এটা দেখেছো? এগুলো দেখাতে বলে যখন কমিউনিটি ভিজিট হয়, এগুলো দেখতে চায়। কমিউনিটি হেলথ ওয়ার্কার যে থাকে সেগুলো দেখে, অঙ্গনওয়াড়ি ও যারা থাকে এগুলো তখন খেয়াল করবে, এগুলো পেছন ছাড়বে না। এখানে আছে তো প্যাথোলজি থেকে শুরু হলো, কমমেডে গিয়ে অবধি চলবে, তারপরে পেডিয়াট্রিক। তো এখন শুরু হলো, পেডিয়াট্রিকে গিয়ে শেষ। সেকেন্ড ইয়ার থেকে ফাইনাল ইয়ার অবধি এইসব জিনিস কিন্তু জানতে হবে, এটা চলবে না। ডায়াগনোসিস অফ স্যাম, হোয়াট ইজ দিস? এখানে কি করছে? মিড আপার আর্ম সার্কামফারেন্স, এইটা একটা ইন্ডিকেটর। যদি মাসল মাস লস হচ্ছে, সাবকিউটেনিয়াস ফ্যাট লস হচ্ছে, তখন এটা অবভিয়াসলি কমে যাবে। সো মিড আপার আর্ম সার্কামফারেন্স ইন চিলড্রেন। আর তাছাড়া বডি ওয়েট ফর হাইট, আর সেটা ছাড়া ফ্যাট স্টোর কিভাবে দেখে? মাসল মাস তো এইভাবে দেখে। আর একটা সেরাম, albumin and transferrin. Now there are 2 compartments of protein. Do you know there are 2 compartments of protein in the body? And yes, somatic and visceral. Somatic মানে যেটা skeletal muscle এ আছে, and visceral মানে which organ? Liver, mainly liver. So আর marasmus and kwashiorkor মধ্যে মেইন যে ডিফারেন্স সেটা কি? somatic compartment and kwashiorkor visceral compartment. So visceral compartment এর indicator mainly হচ্ছে albumin, transferrin, এগুলো serum proteins, and somatic component হচ্ছে mid upper arm circumference, weight for height. So marasmus it develops when diet is severely lacking in calories, right? একদমই কম খাওয়া পাচ্ছে, খেতেই পাচ্ছে না তখন। when weight falls to 60% of normal, less than 60% of normal, যখন weight হয়ে গেল for sex, height and age, then we diagnose it as marasmus. There is depletion of the somatic protein compartment. What are the signs? There will be sunken eyes, the cheek will have very less fat, thin and bony face, the ribs will be clearly visible, there will be growth retardation, frequent infections, apart from that anemia, and the head will appear too large for the body because of growth retardation, and the child will be very, very thin. So the head appears too large for the body. It's a large head on a small body. In these, the visceral compartment is depleted only marginally. So mainly somatic compartment depletion হচ্ছে, visceral compartment not so much, marginally it is depleted. So albumin will not be very low. So which do you think is more harmful or more difficult to treat? কোনটা? kwashiorkor. Why? তাতে কি হচ্ছে? That is why it's more difficult to treat. So they have anemia, multivitamin deficiency, and immune deficiency. A kwashiorkor occurs when protein deprivation is relatively greater than the reduction in total calories. এখানে কি হচ্ছে ক্যালোরি একরকম দিচ্ছে কিন্তু ডায়েটে প্রোটিনটা একেবারেই কম. This word comes from a Ga word. Ga বলে ওই ল্যাঙ্গুয়েজটাকে, in Ghana, it's from African tribe. Ga. তো সেইটাতে kwashiorkor মানে হচ্ছে the disease in a child when a second baby is born. মানে একজন বড়, he or she is actually very small but weaned off very early and a second child has come. So now this child has been weaned off, not getting any milk, and is placed on a rice based diet. The mother is also malnourished, of course. She cannot give adequate milk to both of these children. Now the first child is put on a rice based diet. Now this child is not getting adequate protein. So this disease sets in. What happens in this disease? The liver is now suffering from fatty liver because of decrease in carrier proteins. So there is fat malabsorption, fatty liver is there, and of course there is less protein. Because of this, because of the liver disease, because of low albumin, what will happen? Albumin কম হয়ে গেলে কি হয়? Edema. So now this child will have peripheral edema. So this child will appear fat, but actually this child is severely malnourished. Apart from that, what happens? The intestines, they also have less protein now. So the intestines also will atrophy, the villi will atrophy, and the intestinal glands will atrophy. And what will happen? The disaccharidase will become deficient. So the enzymes are also now deficient, right? Apart from that, of course, there is low immunity, anemia, all that is there. But mainly the intestines have now become atrophied and there is deficiency in the enzyme. So even if this child is given food, excess food, this child will not be able to absorb. তাই জন্যই ওই পুষ্টি ক্লিনিক যেটা বলছি, because then they are given a regimen so that they can be rehabilitated. They cannot be given excess food at home. They need like, of course there is edema, so you have to restrict the fluid, you have to count the amount of fluid you are giving, count the number of calories you are giving, so that this baby is able to absorb properly, right? And the weight is typically 60 to 80% of normal. Apart from that, there is flaky skin. The skin is patchy in places. There is pigmentation, patchy pigmentation on the skin. Apart from that, the hair becomes lusterless and the melanin is less in hair also. So they have lighter colored hair. The hair is loose and comes off easily from the scalp. It becomes thin and wispy. This is how you identify a child suffering from kwashiorkor. So there is growth failure, of course. Growth retardation will be there. Peripheral edema in kwashiorkor, loss of body fat and atrophy of muscle mass in marasmus. Enlarged fatty liver in kwashiorkor because of the reduced synthesis of carrier protein. Mucosal atrophy and loss of villi in small bowel. I have explained this. Hypoplastic bone marrow. Of course, the bone marrow. Now, if you do a bone marrow biopsy or aspiration in these children, what you will see is the cellular components are low for age. Whenever we see the cellularity of bone marrow, we compare it for age, whether or not it is adequate for age. There is a simple formula. If someone is about 1 year old, so the cellularity should be around 90%. 90 to almost 100. So it will be lots of cells basically. And how do we calculate? 100 minus age. So a 70-year-old person will have what cellularity in the bone marrow? 30%. That is simple. So now for these children it will be low. So that is how we know that the cellularity is low in the bone marrow. Also, in which disease we will get cellularity low related to nutrition? I already said this. Anorexia, I already said. That is how you diagnose anorexia also. The gelatinous bone marrow is how you diagnose anorexia. So anyway, in severe acute malnutrition children also, the cellularity will be low, especially the red cell components will be low, and there will be anemia. There will also be vitamin deficiency. So if vitamin deficiency is there, what kind of anemia will be there? Macrocytic. Vitamin B12 deficiency causes macrocytic anemia. Iron deficiency causes microcytic anemia. And there is also something called anemia of chronic disease. So depending on what kind of anemia is predominant, we will get anemia in these children. It can be microcytic, it can be anemia of chronic disease, it can be macrocytic anemia. And there can also be cerebral atrophy in children. If the child, because the brain develops up to 2 years of age, even after the child is born, the maximum brain development occurs by 2 years of age. So if the child is suffering, so even in utero, the child may be malnourished. In malnourished mothers give birth to malnourished children. So this child may have atrophy in the brain if there is acute malnutrition in the first 2 years of life, right? Apart from that, there can be lymphoid hypoplasia. The lymphoid organs will be hypoplastic, the thymus will be hypoplastic, and there is T cell deficiency, and T cell mediated immunity is also low in these children. Hello, next, obesity. Now, what is obesity? Obesity is defined as accumulation of adipose tissue that is of sufficient magnitude to impair health. তো ঘুরিয়ে বেঁকিয়ে বলছে too much fat, যেটাতে পার্সনের হেলথই মেনটেন হচ্ছে না. How do you measure? By the BMI. What is BMI? Yes, how do you measure? Kg, weight in kg by height in meter squared. So what is the normal range? Yes. From 25 to 30, it's up. After that, obese. Above 35 is extremely obese or super obese. এরা তো নড়তে চড়তে পারে না. There are people যাদেরকে নাড়াতেও ঘৃণ লাগে. We have read stories about that. That is how much their lifestyle is not adequate, or that is how much their health is impaired. So this is of course more a problem of higher income countries, but it is also becoming a problem in countries like India. This is what the international books say. Countries like India also have lots of obese people. ইন্ডিয়াতে তো সব রকম লোকই থাকে, we know. There are very rich people, there are very poor people. রিহানা আসে কারো কারো বিয়েতে, এও আসে. So anyway, so obesity is more of a problem is visceral obesity, right? Why is visceral obesity more of a problem? Have you heard of waist hip ratio? What is waist hip ratio? It is a very good indicator of heart disease, right? যাদের visceral obesity বেশি, they are more likely to suffer from metabolic syndrome. What is metabolic syndrome? এগুলো question আসে, long question আসে. কেউ বললো জানি না? হ্যাঁ, কে বললো? কে বললো? Hypertriglyceridemia. Yes. Fat cells itself secrete inflammatory cytokines. So they have a pro-inflammatory state. Their CRP is always raised. That is why now they are suffering from diabetes, hypertension, hypertriglyceridemia and pro-inflammatory state. এই চারটে মিলে হচ্ছে metabolic syndrome. And we all know there are lots of adolescents and children also who are obese. Now energy balance, এটা আছে তোমাদের সিলেবাসে, এটা আছে এনার্জি ব্যালেন্স। What is in the center of energy balance? CNS এর কোনটা থাকে? Hypothalamus. So hypothalamus টা আছে। There are some afferent signals, there are some neurons and the efferent signals, right? This is the so what is the afferent system? Leptin, ghrelin. Leptin ke, who secretes leptin? Yes, adipocytes. Ghrelin লেখাই আছে তো, পড়তেও তো পারো। আর PYY and glucagon like peptide. GLP কোথায় পড়েছো? GLP-1, GLP-2 ফার্মাতে হয়েছে, ডায়াবেটিস, right, and insulin. These are the afferent system. This is the afferent system. Most of these can cross the blood-brain barrier, affect the hypothalamus. Hypothalamus is at the center, and then there is the efferent system. Next, the central processing system is in the arcuate nucleus of the hypothalamus, and there are two sets of neurons, the first order neurons and the second order neurons. What are the first order neurons? POMC CART pathway, এটা একটা ফার্স্ট অর্ডার নিউরন। আর কি? নিউরোপেপটাইড Y and গুটি রিলেটেড পেপটাইড AGRP, এইটা আর একটা ফার্স্ট অর্ডার নিউরন। এটা একটা POMC CART pathway, আর একটা হচ্ছে NPY AGRP। সো এইটা গেল হাইপোথ্যালামাসে। এটা কিন্তু ইফারেন্ট সিস্টেম নয়, দিস ইজ দ্য ফার্স্ট অর্ডার নিউরন, ঠিক আছে? এরপরে হচ্ছে সেকেন্ড অর্ডার নিউরন। সেকেন্ড অর্ডার নিউরনটা কি? একটা হচ্ছে ফর দিস আর একটা হচ্ছে ফর দিস। এইটার যেটা, সেটা হচ্ছে দ্য ক্যাটাবলিক পাথওয়ে। POMC CART pathway is the catabolic pathway and the NPY AGRP is the anabolic pathway, ঠিক আছে? ক্যাটাবলিক পাথওয়েতে কি হয়? ফুড ইনটেক কমছে, এনার্জি এক্সপেন্ডিচার বাড়ছে। অ্যান্ড অ্যানাবলিক পাথওয়েতে কি হয়? ফুড ইনটেক বাড়ছে, এনার্জি এক্সপেন্ডিচার কমছে। তো এখানে হচ্ছে MC3/4 রিসেপ্টর। আর অ্যানাবলিক পাথওয়েতে কি? Y1 and Y5। এগুলো এত ডিটেলসে লাগবে না। You just have to understand there is the afferent system and it goes to the hypothalamus, which is the main regulator, and then there are the first order neurons and the second order neurons, which is the efferent system, which regulates the energy balance of the body. আর ওবিজিটিতে কি হচ্ছে? এই সেন্সরগুলোতে গন্ডগোল হচ্ছে। That is why this person is becoming obese. So what is happening? These are the signals, leptin, PYY, ghrelin. These are going and affecting the POMC and CART pathway or the NPY AGRP pathway. This is in the hypothalamus. Now POMC CART pathway is the catabolic pathway. Catabolic pathway te energy expenditure বাড়ছে, food intake কমছে. How is it? It is the mediator is affected by alpha MSH, melanocyte stimulating hormone. alpha MSH, which is going and affecting the MC34R. This is the second order neurons. Now, ekhan theke second order neuron is stimulating the release of TRH, CRH and BDNF. BDNF is brain derived natriuretic factor. TRH you know, regulating hormone, TRH, CRH, এটা জানো তো? ফিজিওলজিতে এগুলো হয়েছে তো। টিআরএইচ সিআরএইচ কে, টিআরএইচ আর সিআরএইচ এর কাজ কি? তো ওটার কাজ কি? ওই হরমোনের কাজ কি? एनर्जी एक्सपेंडिचर बढ़ाए, हीट बढ़ाए, एनर्जी एक्सपेंडिचर बढ़ाए। and এখানটা যেটা NPY, this is the anabolic pathway, NPY AGRP pathway, সেটা থেকে কি হচ্ছে Y1 and Y5 receptors এর উপর কাজ করছে, সেখান থেকে তার which is the second order neuron, Y1 and Y5 receptors, এই Y1 and Y5 receptors are secreting orexins and MCH. Orexins and MCH, these are the anabolic, this is the mediators of the anabolic pathway. তাতে কি হচ্ছে food intake is increasing and energy consumption is decreasing. এই অরেঞ্জ কালার বা পিচ কালারটা হচ্ছে anabolic and this purple color is the catabolic pathway. So now the components of the afferent system. একটা হচ্ছে leptin. Leptin is secreted by the adipocytes. What happens is leptin, what it is doing is catabolic pathway কাজ করছে. So what happens is in mice there is leptin, there are some genetic, it has been found that there are some genetic mutations where leptin secretion is decreased, right? That is also found in humans. In some humans who are obese, there is decreased leptin in the body. Apart from that, leptin sensitivity, leptin receptors are not functioning. So even if leptin is high in obese individuals, leptin receptors are not working, and that is why they are becoming obese, because the catabolic pathway is not working properly. So leptin was isolated by the scientists and they thought it can be a wonder drug. It can decrease, it is the answer to all problems. কোন দেশের মানে যেই দেশে যেই রোগ বেশি সেই দেশে সেই রোগেরই রিসার্চ বেশি হয়। USA তে obesity বেশি, obesity research ও প্রচুর হয়। So they are desperate to find drugs that can reduce obesity so that people can eat whatever they want and they will not become obese. But leptin did not work. Unfortunately, leptin does not work because obese individuals have defective leptin receptors. Apart from that, adiponectin, it is the guardian angel against obesity. Adiponectin is the guardian angel against obesity. What happens? It is also produced by adipocytes. It is a fat burning molecule. It reduces fatty acids by promoting their oxidation. Right? Fatty acids can also, some fatty acids are crossing the blood-brain barrier and stimulating the hypothalamus, and then fatty acid oxidation is increased. So fat is burnt. Apart from that, it has anti-atherogenic property. Adiponectin has anti-atherogenic property, anti-inflammatory property. So ja problem ache obesity te, atherosclerosis is a problem, pro-inflammatory state is a problem. So এইগুলো সব কিছু কমায় adiponectin. So it is called the guardian angel against obesity. Right? তো এদের দেখা গেছে অ্যাডিপোনেকটিন কম থাকে, অ্যাডিপোনেকটিনেরও সেন্সিটিভিটি কম থাকে। Apart from that, there are the gut hormones. Ghrelin, it is secreted by stomach, it increases food intake. খাবার প্রথমে স্টমাকে গেল and food intake is increased because of secretion of ghrelin. And PYY and GLP-1, these are secreted by intestine and cause a decrease in food intake. Okay? And metabolic syndrome যেটা ও বললো, তোমার নাম কি? কি? নবরূপ। So anyway, adipocytes produce cytokines and chemokines, right? এগুলো কি হয়? Pro-inflammatory state তৈরি হচ্ছে, right? সেইটাতে কি হচ্ছে, অ্যাথেরোস্ক্লেরোসিস বাড়ছে, এদের সিআরপি ইজ অলওয়েজ রেজড। সিআরপি ইউ নো, it is, C reactive protein inflammation indicator. If there is any inflammation in the body, CRP will be raised. So in obese individual, CRP is always raised. Apart from that কি হচ্ছে, triglycerides বাড়ছে, এইটার থেকে triglycerides বাড়ছে। আর একটা কি হচ্ছে, ইনসুলিন এদের বেশি থাকছে। ওবিসিটিতে কি থাকে, পেরিফেরাল ইনসুলিন রেজিস্ট্যান্স, ইউ নো দিস। পেরিফেরাল ইনসুলিন রেজিস্ট্যান্সের জন্য কি হয়, ইনসুলিন সিক্রিশন বাড়তে থাকে, বাট দ্য বডি ডাজ নট সেন্স, সো দ্যাট ইজ ওয়াই। আর তাছাড়া ইনসুলিন রিসেপ্টার্স বাড়তে থাকে, ইনসুলিন অলসো অ্যাক্টস অ্যাজ আ গ্রোথ ফ্যাক্টর। ওটাতে আরও কি হচ্ছে, স্মুথ মাসল স্টিমুলেট হচ্ছে, স্মুথ মাসলগুলো বেড়ে যাচ্ছে, কোথায়, ব্লাড ভেসেলে স্মুথ মাসল বেড়ে যাচ্ছে, তাতে কি হচ্ছে, কনস্ট্রিকশন হচ্ছে। আর কি হচ্ছে, কনস্ট্রিকশনের জন্য হাইপারটেনশন হচ্ছে, রাইট, হাইপারটেনশন হচ্ছে। আর কি হচ্ছে, অ্যাথেরোমা ফর্মেশন হচ্ছে, রাইট। আর কি হচ্ছে, সোডিয়াম রিটেনশন হয়, বিকজ অফ দিস there is also sodium retention. What all this will cause, hypertension. তো হাইপারটেনশনের একটা মেন ট্রিটমেন্ট কি হবে, ওয়েট রিডাকশন। ফার্স্ট লাইন অফ ট্রিটমেন্ট ইজ ওয়েট রিডাকশন। এগুলো আগে ছিল না, আগের যে জিএমসিগুলো ছিল সেই জিএমসিতে এগুলো আসতো না, কিন্তু এখন নাম্বার ওয়ান ট্রিটমেন্ট ইজ ওয়েট রিডাকশন ফর হাইপারটেনসিভ ইন্ডিভিজুয়ালস। হ্যাঁ, আর একটা হচ্ছে গাট মাইক্রোবায়োম। আর একটা জিনিস আমি বলতে ভুলে গেছিলাম, দিস ইজ সামথিং ইন্টারেস্টিং। First, I will talk about this. The gut microbiota in obese individuals is different from that in normal lean individuals. The bacteria in the gut of these individuals is able to get more energy from calories and store more energy than the microbiota in lean individuals. So, at obese individual, you take the gut microbiome from that individual and experimentally you inject it to normal mice. What happens? This mouse now becomes obese. This, okay. And also in protein energy or severe acute malnutrition, there also gut microbiota plays a role. If you take the gut microbiota from a person suffering from severe acute malnutrition and you inject it to normal mice, what happens? This mouse now starts suffering from severe acute malnutrition. যেটা বললাম সেটার এটা একটা সামারি। সো ফ্যাট adipocytes are secreting leptin. The parietal cells of stomach are secreting ghrelin. The pancreas is secreting insulin, and peptide YY are secreted also by the enterochromaffin cells of the intestine. Now, what is this? These are the signals of the afferent system. The afferent system is now working in the hypothalamus arcuate nucleus, and then there are the effectors which can cause energy. This can cause energy balance is maintained, and there can be energy expenditure or increased food intake by the efferent system. So now, what are the consequences? This is also included in your syllabus. So there is metabolic syndrome, hypertension. I've already spoken about metabolic syndrome, hypertension, diabetes, cancer, hypertriglyceridemia, and low HDL. In these individuals and people suffering from metabolic syndrome, there is hypertriglyceridemia and low HDL. Lipid profile is deranged. What else is there? Insulin resistance, hyperinsulinemia. NAFLD টা কি? Non-alcoholic fatty liver disease. So these people are also, usually they suffer from non-alcoholic fatty liver disease. In most affluent individuals, you go and do a USG. Even the overweight individuals, they will always write grade 1 fatty liver. USG kora, grade 1 fatty liver. Lekha start hoye jay. Cholelithiasis, why? Why is there cholelithiasis? excess cholesterol is there in their body, it is secreted from the bile. Bile is concentrated in the gallbladder. So, gallbladder will have cholesterol stones. Gallbladder stone এর একটা F দিয়ে একটা mnemonic আছে জানো? Fat 40 fertile female. So, fat is there, right? Excess fat will cause excess cholesterol stones in the gallbladder, and this will cause cholecystitis. Apart from that, obstructive sleep apnea and Pickwickian syndrome. You've heard of Pickwickian syndrome in physiology? Have you read Pickwick papers? ওটা একটা বই by Charles Dickens. So there was this person who was in that book, which I also haven't read, but the syndrome comes from that name. There was a character in the Pickwick papers. He was always sleeping and was very fat. Why? Because of obstructive sleep apnea. Obstructive sleep apnea causes congestive right heart failure. So obese individuals have hypoventilation. এতটাই পেটটা বড় যে lung is not getting enough space to expand. So they have hypoventilation and shallow breathing, especially when they sleep. So obstructive sleep apnea. Have you seen fat drivers? This has happened to me several times. Fat drivers who fall asleep, signale দাঁড়িয়ে ঘুমিয়ে পড়ে. I have faced this twice in my life. I was very scared. So what happens is they are suffering from obstructive sleep apnea. They are not getting adequate sleep. When they are at night, they are not getting adequate sleep. They snore, their tongue falls back. They snore. What happens is oxygen is low in their body throughout the night, and because of that they suffer from heart failure. Eventually it leads to heart failure. তো এদেরকে কি দিতে হয়? Firstly weight reduction, যেটা জীবনে হবে না, এদেরকে positive pressure ventilation দিয়ে ঘুম পাড়াতে হয়. And you have seen these contraptions which some fat people use when they sleep. এটা আছে, অনেকে ইউজ করে, জিজ্ঞেস করবে ENT তে এটাই পড়াবে, এটা একটা লং কোয়েশ্চেন. So anyway, Pickwickian syndrome also because of hypoventilation, these people have heart failure, so that is also a problem. Osteoarthritis কেন হচ্ছে? Because এটা একটা জেনারেলাইজড লজিকে ভাবো, এদের পাটা এতটা ওয়েট ক্যারি করতে হচ্ছে, জয়েন্ট ঘষা খেয়ে 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 জয়েন্টগুলো যাচ্ছে. তো মোটা লোক মানেই দেখবে অস্টিওআর্থ্রাইটিস, স্পেশালি আ প্রবলেম ইন চিলড্রেন. যেই সব adolescents and children are obese, they osteoarthritis sets in much earlier in those children. Young children can also suffer from osteoarthritis because they are so fat. And pro-inflammatory state I have already, because adipocytes themselves they release cytokines, especially interleukin 1, TNF alpha. This causes a pro-inflammatory state in the body. Obesity can also increase risk of cancer. These are the cancers which can occur because of obesity. কেন? Pathogenesis. একটা হচ্ছে যে এদের হরমোনস গুলো ডিরেঞ্জড আছে, right? Because of hormonal derangement, there is continuous stimulation of the lining of the say endometrium or breast-এর glandular tissue. এগুলোর গ্রোথের একটা continuous. Why is you know this that breast cancer is a disease of the educated, of the literate, of the developed people. Why? One reason is obesity. They are usually overweight. They may smoke also. So because of this, the breast is actually constantly stimulated, and this can give rise to breast cancer, can give rise to endometrial cancer, can give rise to thyroid cancer. Apart from that, pro-inflammatory state gives rise to, can give rise to cancer. Apart from that, insulin is a stimulates growth. I've already said this, insulin stimulates growth. So So that the continuous stimulation of growth can also give rise to cancer. Apart from that, adiponectin. Adiponectin reduces the inflammation. It also has a beneficial effect to play on P53, P21. This is the guardian of the genome, last class. So this can also, so adiponectin actually stimulates apoptosis, right? So if there is low adiponectin, apoptosis is not stimulated, it's inhibited, and that can also give rise to cancer. Cancerous cells are now getting the chance to grow.
Where we use general anesthetics? Any surgical intervention, especially major surgical intervention where there is a reversible loss of sensation. Among the all sensation, the most important sensation to be lost during a surgery is pain. So it is all are the reversible one. Reversible loss of pain, all sensations, specifically pain, unconsciousness and amnesia, it is also reversible one. Immobility, muscle relaxation, all are the reversible, and abolition of the reflexes. It may be a somatic or autonomic reflex. So reversible loss of pain, reversible loss of consciousness, reversible loss of memory, loss of somatic and autonomic reflexes, as well as muscle relaxation. All these are reversible in case of general anesthesia. If it is irreversible, what is this situation? When all these are loss of reflexes, loss of consciousness, if it is in irreversible state, it is death. So it is the reversible one. The reversible loss of consciousness, sensation, memory and autonomic reflexes. The principle of the general anesthetics, the unconsciousness. Unconsciousness, the action occurred in the reticular activating system or RAS. RAS, if there is a in the thalamus, RAS is involved to produce the unconsciousness. For amnesia, hippocampus and cortex is involved to produce amnesia. For immobility, the spinal cord. So location and their effects. There are two theories. One is unitary theory and one is agent specific theory. Nowadays we are more precise on the agent specific theory. There are different mechanisms by which the general anesthetics produce these actions. What are their actions? Primarily general anesthetics. Reversible loss of consciousness, reversible loss of sensation, amnesia, produce reversible amnesia, reflexes. So GABA A receptor, which is chlorine mediated. It is the most important for the inhalational anesthetics as well as barbiturate and benzodiazepine and effects like propofols. Second one, interaction with its own specific binding of GABA A and chloride complex that produce hyperpolarization, and that causes this sedation of the CNS. Next is glycine. Glycine also acts through the chloride channel. GABA, glycine. Third one is nicotinic cholinergic receptor. Nicotinic cholinergic receptor, they primarily produce analgesia and amnesia. Nicotinic cholinergic receptor. So GABA, glycine, nicotinic cholinergic receptor. NMDA type of excitatory receptor. They primarily act through N2O, nitrous oxide, and some hyperpolarization of the gases. So receptors important for general anesthetics are GABA, chloride mediated, glycine, chloride mediated, then আর কি দুটো ছাড়া বলো, excitatory receptor inhibition by NMDA. These are the and the direct gas effect. Excitatory NMDA is blocked by the N2O, nitrous oxide. Then pharmacokinetic. The pharmacokinetic of inhalational, there are two types of general anesthetics. One is inhalational general anesthetics and one is intravenous one. So for inhalational, the inhalational anesthetics in gaseous form given from the outside and it goes into the alveolus. From the alveolus, there are surrounding blood vessels. So it goes into the blood from the alveolus and through the blood it goes into the CNS. So there are blood from gas from the there is a equilibrium between alveoli and the blood and blood with the brain. The blood with the brain and there is a equilibrium of the gas. So there are the factors which is important for this general anesthetics. Partial pressure of the general anesthetics in the inspired air. If it is high, what happen? And if it is low, what will happen? Partial pressure of general anesthetics, if it is high, the concentration deviation will be high. So there is a rapid onset of prominent general anesthetic action. Second one is pulmonary ventilation and alveolar exchange. Pulmonary ventilation, if it is increased, the onset will be high. Similarly, alveolar exchange. Now, solubility of the gas in the blood. If the general anesthetics is high solubility in the blood, what happen? Blood e jodi solubility beshi hoy, the equilibrium will be shift. So there will be less or later onset of this action. But if it similarly, if solubility of the gas is high in the tissue, for this specifically brain tissue, recovery will be late. Solubility of the blood will reduce the onset. Solubility in the brain will reduce the delay the recovery. And cerebral blood flow, if it is increased, more amount of gas will go into the brain and that can produce sedation. That means anesthesia, general anesthesia will be profound. So all these partial pressure, pulmonary ventilation, alveolar exchange and cerebral blood flow will, if it is increased, onset will be high, earlier. Whereas in case of increased solubility of the drug in the blood, it will reduce or delay the onset, and solubility in the tissue delay the recovery of the general anesthetics. Now, Goodell in 1920, they stages the different phase of this anesthesia. The important thing is the name of the person who staged that is Goodell, and which anesthesia, that is ether anesthesia. There is 4 stages. Stage of analgesia, followed by stage of delirium, then surgical anesthesia and medullary paralysis. So there are 4 stages. Among them, the third surgical anesthesia. In surgical anesthesia, most of these surgical procedure done in the surgical anesthesia. So, and in delirium stage and the medullary phase, we shouldn't avail in the medullary stage, and in the second stage, we shouldn't do anything, shouldn't do any procedure. But in the analgesic stage, we can do some limited sort of procedure. Tooth extraction type of procedure can be done previously, but majority of the operation should be done in the stage 3, surgical stage of anesthesia. This stage has 4 planes. Plane 1, plane 2, plane 3, plane 4. 1 ends with the fixation of the eyeball. 2 completed with the corneal and laryngeal reflexes. 3, loss of right reflexes is completed. So it is important. So there are 4 stages. Which anesthesia denote that? Ether anesthesia. Goodell in 1920 described 4 stage. One is stage of analgesia, delirium, then surgical and medullary paralysis. Among these, most of these surgical procedure done in the 3rd stage. 3rd stage has 4 planes, and among this plane, corneal and laryngeal reflexes is lost in plane 2, corneal reflexes and light reflex is lost in the stage 3. It is important for your MCQs. How many stage, how many plane, and which plane we lost the corneal reflexes, which plane we lost the light reflexes, and in which stage we shouldn't have a procedure. Which stage? If 1, 2, 3 and all of the above. 2. Major surgical operation done in the stage 3 and some minor procedure done in the stage 1, that is stage of analgesia. So classification, if we classify it inhalation and intravenous, in the inhalation we can distribute it in 2. One is gaseous agent. Gaseous agent is nitrous oxide, whereas in the volatile liquid it is ether, halothane, isofluorine, desfluorine and sevofluorine. These are the agents of volatile liquid. And there is a intravenous one. In the intravenous there is fast acting and slower acting. Fast acting are primarily used for induction of the general anesthesia, whereas the slower acting are used for maintenance. So faster acting drugs like thiophantom, propofol and etomidate, whereas maintenance drugs are benzodiazepine, ketamine and fentanyl. Fentanyl is also a opioid drug used in general intravenous general anesthetics. So there is a gaseous one, there is a volatile liquid, and intravenous. In intravenous, one is induction agent, one is maintenance agent. Clear এই পর্যন্ত? ড্রাগগুলোর নামগুলো বলতে হবে। ইন্ডাকশন এজেন্ট কি আছে? থায়োপেন্টন সোডিয়াম, প্রোপোফল, ইটোমিডেট, whereas slower acting are ketamine, fentanyl and benzodiazepines. Benzodiazepines already covered or not? Diazepines হয়েছে? Sedative হয়ে গেছে? They can be used primarily. Benzodiazepine used in which clinical situation? Benzodiazepine কোথায় ইউজ হয়? Insomnia. Very good. What are the different benzodiazepines other than benzodiazepine? What are the different sedative or hypnotic? Barbiturates are jet drugs. There are 3 groups. Which one preferred mostly? Jet drugs. Why? Quality of sleep are side effects. Which one has most side effect? Barbiturate. Which can cause toxicity? Most toxicity. Which has an antidote? Benzodiazepine has an antidote. Which one has a steeper dose response curve? Barbiturate has the most steeper dose response curve. Barbiturate is not used as a general anesthetics, but benzodiazepine are. So in the benzodiazepine is a induction or maintenance group of drug. Maintenance. Induction group of drugs are the fast acting, thiopentone sodium, like propofol, etomidate. These are induction, they are fast onset, whereas maintenance are with the slower acting drugs like benzodiazepine, ketamine and fentanyl. So ether, halothane, isofluorine, desfluorine, sevofluorine and nitrous oxide, these are the drugs we used as a inhalational general anesthetics. So give an example of a drug which you Route of administration is inhalation, acts locally. Example of a drug used inhalationally, acts locally, salbutamol, tarbutaline, and inhalational steroids. And give a name of some drugs which route of administration is inhalation and acts systemically. Inhalational general anesthetics like nitrous oxide, ether, halothane, isoflurane, sevoflurane, desflurane. Clear? These are the group of drugs used in a route of inhalation, acts systemically. First one is nitrous oxide. It is a colorless, odorless, non-inflammatory, non-irritant agent. The physical property. It has a very good analgesic property, but it has a very minimal muscle relaxant. Analgesia মানে pain relief করে কিন্তু muscle relaxant করে না। তাতে কি হবে? We should add a muscle relaxant. কি muscle relaxant আছে? Muscle relaxant পড়ানো হয়েছে? কি আছে? দুটো group of drug আছে, depolarizing and non-depolarizing. Then with the nitrous oxide, we require to add the full scale of muscle relaxant because they doesn't have have a very minimal effect of the relaxation of the muscle. So it requires neuromuscular blockers. So it is a colorless, odorless, non-inflammable, non-irritant, low potency drug. Low potency. But it has a very good analgesic, very poor muscle relaxant property. Onset is quick and smooth. Recovery is rapid. But it requires other drug or helps other drug to produce second gas effect, and it also have a effect of diffusional hypoxia. We will discuss these two terms. There are 4 terms. One is MAC, minimal alveolar concentration. Second one is second gas effect. Third one is diffusional hypoxia. We will describe these 3-4 terms at the last of this class. So MAC, you have to understand, if MAC is high, minimal alveolar concentration is high, then what happens? The drug will be less potent. It is less potent and it is irreversibly, inversely proportional to the MAC with the potency of the inhalation general anesthetics. MAC is 105%. So it is a very poor general anesthetics. So how it used? It used 70% of nitrous oxide along with the 30% of the oxygen and muscle relaxant. They can produce optimal general anesthetics. Post anesthetic nausea vomiting is less. Increased sympathetic tone which counteracts with the direct depression action of the heart and circulation. The main thing is that it is a very good analgesia with very less muscle relaxant, and it is a very high MAC that indicates it is a very poor or very inefficient general anesthetics. It requires oxygen and muscle relaxant and add on some other general anesthetics to produce a good general anesthesia. The combination is primarily used 70% of nitrous oxide, 20 to 30% of oxygen along with the 0.2 to 2% of the halothane. Primarily halothane or other inhalational anesthetics. Sole agent of nitrous oxide with oxygen can be used in dental extraction and obstetric cases, but not major abdominal, thoracic or cranial surgeries. It is used because of its low cost. And next one is ether. Ether is a volatile liquid. It is a irritant, inflammable and explosive, not used in the developed country. তাহলে আমরা যদি if we compare with the nitrous oxide, which one is safer? nitrous oxide, because it is colorless, odorless, non-inflammatory, non-irritable. Whereas ether is, though it is a very inflammatory, inflammable, and it can produce some, if it is banned in the developed country. But it has a very potent anesthetics, produce good analgesia, marked muscle relaxant. So if we compare analgesia, both are very good analgesia, but muscle relaxant, which is in better? Ether is better. Ether is better than nitrous oxide. But it highly soluble in the blood, induction is prolonged. Induction is prolonged and unpleasant. So struggling, breath holding, respiratory distress is high. Similarly, its recovery is slow and it can produce post-anesthetic nausea, vomiting. So in this, if we compare nitrous oxide, it is a faster onset, rapid recovery, and there is a smooth, there is less amount of breath holding or respiratory struggling. But the one good point of the ether as an anesthetic in comparison to the nitrous oxide is it is a better muscle relaxant. It is not sensitized heart for the adrenaline. If sensitization of the heart with the adrenaline, that can produce tachycardia as well as hypertension, and it is not also a hepatotoxic. It is not a hepatotoxic. It is cheap. It can be used in an open drop method and relatively safe in inexperienced hand. The importance of the ether is, though it is inflammable, but it has a very good muscle relaxant property in comparison to the nitrous oxide. Whereas another important thing of the ether, through the ether anesthesia, Goodall have these stages. Stages of the anesthesia is done by Goodall in 1920. How many stages are there? How many stages? 4 stages. Number 1, analgesia, delirium, surgical, medullary paralysis. কোথায় অপারেশন হয় সাধারণত? In which stage? Stage 3, surgical. It has a 4 plane. Loss of corneal reflex in the plane? Plane 2. Loss of light reflex, plane 3. Halothane, it is a volatile liquid. It has a very sweet odor, non-irritated, non-inflammable. It is a potent anesthetics. It is not good analgesic or muscle relaxant in comparison to the other. Other means compared to nitrous oxide or ether. It can cause reduced heart rate, vagal stimulation, direct depression, along with the absence of receptor reflex leading to the fall of BP. But it has a smooth or sweet smell. Bad thing is, adverse effect is sensitization of the heart, as well as they can produce respiratory depression. Respiratory depression can be controlled by mechanical ventilation. So in general anesthetic, primarily we do a intubation and mechanical ventilation to control the loss of ventilatory failure, to control the ventilatory failure. It increases the cerebral flow, ventilatory support along with the oxygen, helpful for this. It also relaxes the smooth muscle, tracheobronchial tree. So it is helpful in the asthmatic, where there is a spasm in the tracheobronchial smooth muscles. It inhibits why it should not, halothane should not be used in case of pregnancy or pregnancy delivery. During that time, we should not use halothane. Cano? It reduces the uterine contraction. If there is a reduction of the uterine contraction, what will happen? There will be 2 problems. Number 1, there is a delayed delivery, difficult delivery. Number 2, even after delivery, the uterine contraction will be less, and that can lead to কি বলে তাকে postpartum hemorrhage. So in these two situations, due to this, it should not be used in pregnancy, but it is preferred in the asthmatic patient. The most important side effect is hepatitis, especially when recurrent use of or twice or thrice use of halothane anesthesia in a patient, they are more prone to the hepatitis. Liver, that can lead to liver failure. So the side effect, it can sensitize the heart, it can prolong labor, it can induce PPH, it can also produce some hepatitis. Now most of these general anesthetics, inhalational general anesthetics, how it excreted or their action is terminated, how any drug action is terminated, metabolism or excretion. So now most of these inhalational anesthetics, they go into the body through the respiratory system. So from the alveolus to the blood to the brain, site of action. Now when we discontinue this circuit or partial pressure is reduced, what happen? কি হবে? রিভার্স হয়ে যাবে। তাহলে without any metabolism, these drugs, inhalational anesthetics, excreted primary through the which organ? Because lungs দিয়ে ঢুকলো, পার্সিয়াল প্রেসার যেই চেঞ্জ হলো, তখন কি হবে? প্রথমে অ্যালভিওলাসে যে কনসেন্ট্রেশন থাকবে সেটা আস্তে আস্তে বেরিয়ে যাবে রেসপিরেশনের সাথে। তাহলে ব্রেন থেকে কনসেন্ট্রেশন ব্লাডে চলে আসবে, ব্লাড থেকে অ্যালভিওলাসে আসবে। It will reverse the concentration, and the expulsion of this inhalation anesthetics is due to respiration through the lung. Whereas halothane is one of the inhalational anesthetics, they have a 20% metabolism in the liver. The catch is that most of the inhalation anesthetics excreted to the lung. Which one has a metabolism in liver? Or which general inhalational anesthetics have metabolism in liver? Halothane. Halothane has a significant amount of metabolism in liver. Another side effect is malignant hyperthermia. Malignant hyperthermia associated with halothane and other fluorinated inhalational anesthetics like enflurane, isoflurane, but halothane is the most important. One is inhalational fluorinated anesthetics like halothane, and other group is succinylcholine. Succinylcholine is used in কি গ্রুপের ড্রাগ? এটা মাসেল রিল্যাক্সেন্ট। আর একটা মাসেল রিল্যাক্সেন্টের গ্রুপের নাম কি? কুরারাইন। এটা কি তাহলে? ডিপোলারাইজিং আর নন ডিপোলারাইজিং? সাকসিনাইলকোলিন কম্পিটিটিভ না নন কম্পিটিটিভ? কম্পিটিটিভ নন ডিপোলারাইজিং ইজ সাকসিনাইলকোলিন। দুটো গ্রুপ অফ ড্রাগ আছে, ডি টিউবোকিউরারাইন আর সাকসিনাইলকোলিন। একটা গ্রুপের নাম হচ্ছে ডিপোলারাইজিং নন কম্পিটিটিভ, আর একটা হচ্ছে কম্পিটিটিভ নন ডিপোলারাইজিং। কোনটা কম্পিটিটিভ নন ডিপোলারাইজিং? Curarine is a competitive but non-depolarizing, whereas succinylcholine is a depolarizing non-competitive. Clear? এগুলো মনে রাখতে হবে। Then another thing is malignant hyperthermia, where there is a high temperature with muscle rigidity and breakdown of muscle leading to myoglobinemia, myoglobinuria. that can lead to renal failure too. This is called hyperthermia. This is caused by two types of agent. One is halothane group of drug or halothane fluorinated inhalational anesthetics. Other group is depolarizing non-competitive type of muscle relaxant, namely succinylcholine. So when we used halothane with succinylcholine, is it a situation when we can use both? In general anesthesia, we require analgesia, loss of reflexes, as well as muscle relaxant. So we can use, and this situation that can lead to hyperthermia. Malignant hyperthermia is due to an abnormal calcium channel that is called ryanodine type of receptor stimulation that can lead to malignant hyperthermia. তাহলে malignant drug induced malignant hyperthermia কি কি লিখতে হবে? Causative organ, causative agent কি কি? Halothane group of inhalational general anesthetics আর 2 নম্বর হচ্ছে depolarizing non-competitive type of muscle relaxant. They stimulate ryanodine type of calcium channel and sign and symptom কি হবে? Hyperthermia, muscle rigidity, myoglobinuria, myoglobinemia. Dantrolene is a drug which used to terminate this or used in malignant hyperthermia. MCQ আসতে পারে causative agent কি, which receptor is involved. Why it is important? It is important because it is cheap, non-irritant, non-inflammable, suitable for children both for the induction. It is important in children both for the induction as well as maintenance. But in case of adults, it mainly used as a maintenance. Induction আর maintenance এর মধ্যে পার্থক্য বুঝতে পারছো? Induction মানে হচ্ছে প্রথমে পেশেন্টটাকে আনকনসাস করা, সেই জন্য কোন ড্রাগ লাগবে? যেটা র্যাপিড অনসেট। তারপর মেনটেনেন্সের জন্য যে ড্রাগটা দেওয়া হবে সেটা স্লো অনসেট হলেও চলবে, কিন্তু দেয়ার ডিউরেশন অফ অ্যাকশন শুড বি লং। ক্লিয়ার? তাহলে ইন্ডাকশন এজেন্ট ইজ অনসেট ইজ স্পিডি অনসেট, recovery will be speedy. So we use two types of drug. One is for induction, they have a fast onset, and then we use the drug for maintenance which duration of action is high. Clear এই পর্যন্ত? Deficiency, it is a poor analgesic as well as muscle relaxant property. Concomitant use of nitrous oxide as well as opioid and neuromuscular blocker is required, but it is used more than ether and nitrous oxide in case of developed country. But nowadays they shift into the other fluorines like isofluorines. They have a rapid induction and recovery. They have a well maintained, the side effects of halothane is reduced in case of isofluorine. That means heart sensitization is less than the halothane. Cardiovascular effect probably results in stimulation of the beta adrenergic receptors, but it does not sensitize heart. Sensitize heart ke kore tale? Which agent, which anesthetics? Halothane. Halothane can sensitize heart to the adrenaline. Enfluorine, another fluorines, they can produce seizures, rarely used nowadays, but isofluorine doesn't have this side effect of seizures. Seizures means convulsion. Which one produces convulsion? Enfluorine. Isofluorine doesn't have this seizure, and it is suitable for neurosurgery. Isofluorine is very good agent for neurosurgery. Desfluorine, it is used for daycare surgery. Desfluorine for daycare surgery. Then sevofluorine for pediatric surgery patients. তাহলে isofluorine used in primarily a very good agent for isofluorine neurosurgery. day care surgery, desflurane. And sevoflurane is very good agent for pediatric patient. Clear? Now the fourth term is first is the MAC, minimal alveolar concentration. As the name said, it is the lowest concentration of the inhalational general anesthetics that can produce the immobility of 50% of the subject in a surgical incision. The important thing is that MAC is minimal alveolar concentration. It is the lowest concentration of the agent in the alveolus that can produce a immobility in 50% of the patient, 50% of the subject at their lowest concentration. So it indicates the potency of the general anesthetic. So if MAC is high, potency will be clear to. তার মানে কি মিনিমাল কনসেন্ট্রেশনটা খুব হাই, তবে সে একটা ইনসিশনটা দিলে তার কোনো পেন সেন্সেশন হচ্ছে না, কোনো রিফ্লেক্স কাজ করছে না। সো ইফ MAC is high, that indicates the potency of that general anesthetic is low. So if nitrous oxide MAC is 105, then it indicates nitrous oxide is a very less potent. It is the less potent and general anesthetics. Second gas effect means when we give nitrous oxide, as it has a very poor solubility and MAC is less, we require high amount of nitrous oxide to be given. We have to give 1 liter per minute nitrous oxide. Along with that, if we mix other inhalational anesthetics like halothane, only 0.2 to 2%, we give this high amount of halothane that can produce general anesthesia. So it is the effect of the second gas, that is halothane or other sevoflurane, primarily halothane, that can produce this is called the second gas effect, not for the nitrous oxide but for the halothane. This is called the second gas effect. Clear? Because of its low solubility and high MAC. Then diffusional hypoxia. So diffusional, after discontinuation of with the machine, what happened? Now nitrous oxide as well as halothane and oxygen comes out from the body. Least soluble is nitrous oxide, and it will fill the lungs by replacing the oxygen. Clear? যার লো সলিবিলিটি সে তাড়াতাড়ি বেরোবে, লাংটাকে পুরো ভর্তি করে দেবে, তাহলে কি হবে? অক্সিজেন রিপ্লেস হয়ে যাবে, there will be a hypoxia. To prevent that, what will you do? After discontinuation of general anesthetic gas, we continue with the oxygen. So oxygen pressure will be there and less amount of hypoxia will be there. Clear? So there is a term called ideal anesthetics. It is usually different for different person. Like surgeon, they require adequate analgesia, immobility or muscle relaxation. For patient, it should be pleasant, non-irritating. And for the anesthetic purpose, they require the margin of safety, smooth induction, quick recovery, less amount of stimulation of CVS, abnormality in CVS. All these are important for the anesthetics. So ideal general anesthetics is a misnomer. It is different for different group of people. For patient, it should be smooth. For the surgeon, it should be potency will be high, it should be duration will be high, and for the anesthetics purpose, there it should be smooth onset, rapid recovery, and there should be not be any adverse event during the anesthesia. So this MAC, second gas effect, diffusional hypoxia, are properties of the ideal gas. And last one is the pre-anesthetic medication. There are some drugs which is used to reduce the anxiety, to reduce the side effect, or smoothening the general anesthetics onset of the action. So for that, to reduce anxiety apprehension, produce some amnesia, decrease secretion and vagal stimulation, some antiemetic effect. Antiemetic effect why it is required? Because if there is if there is a reflux will be there, there may be some aspiration to prevent that. All these are the aims of the pre-anesthetic medication. For that we used some sedative and hypnotic or anxiety key drug there. Benzodiazepine group of drug. Then some opioids for the add-on analgesic effect. Then anticholinergic. Why anticholinergic is important? To reduce secretions. Tracheobronchial trachea secretion and GI secretion will be reduced. Some neuroleptics that can also have some anticholinergic effect. Proton pump inhibitors and antiemetic to prevent the refluxes. These are the use of different drugs as a pre-anesthetic medication. So in inhalation general anesthetics, for short note or MCQ, for MCQ purpose, or for the Viva, MAC, second gas effect, diffusional hypoxia and pre-anesthetic medication. Tarpore ki? For Viva, what are the different stages and different planes? In which stage or which we do this primarily the surgical surgeries. Which stage should not be reached and which stage we should not do any surgery. And there is a difference between induction agent and maintenance drug. Clear? And what is the primary role of this general anesthetic? Reversible loss of key loss? Sensation, memory, reflexes and mobility. All should be reversibly lost. ঠিক আছে? তাহলে we covered this inhalation general anesthetics. এখান থেকে আর কি এজেন্ট অ্যাজ এ শর্ট নোট আসতে পারে? নাইট্রাস অক্সাইড, তারপরে ইথার, হ্যালোথেন, আর ফর এমসিকিউ আইসোফ্লুরেন অ্যাজ এ শর্ট নোট, আর ফর এমসিকিউ সেবোফ্লুরেন কোথায় ইউজ হয়, ডেসফ্লুরেন কোথায় ইউজ হয়, কোন সার্জারিতে আইসোফ্লুরেন প্রেফার্ড, কোথায় আইসোফ্লুরেন প্রেফার্ড? নিউরোসার্জারি। ঠিক আছে? হুইচ ওয়ান ইজ ইনফ্লামেবল, হুইচ ওয়ান হ্যাজ better analgesic effect but no muscle relaxant, which good analgesic but low muscle relaxant? Nitrous oxide. Good analgesic, good muscle relaxant, ether, but it has a inflammable property, whereas halothane doesn't have a not a good analgesic effect or muscle relaxant, but for the other cost and others, it is preferred than the ether. ঠিক আছে?